Anxiety and Obsessive Compulsive Disorder, Chapter 15. These are the terms and that you will need to be familiar with, including making sure you are familiar with all of the defense mechanisms that we utilize when we have anxieties. Remember the difference between Freud's defense mechanisms and Sullivan's interpersonal anxieties. We talked about some of this in chapter 2 with our theorists, and then here again it comes back again to represent itself here in our anxiety chapter. So what we're going to do is start off with talking about our 4 levels of anxiety and our defense mechanism that we use. So anxiety talks about the fact of apprehension, uneasiness, uncertainty, or dread from real or perceived threat. Remember that, real or perceived. Fear is a reaction to that specific danger. So you have to have anxiety before you have fear. And normal anxiety is necessary for survival. So there's mild anxiety, which is every day. We need to have that. It's part of our ability to problem solve. It gives us leverage. It helps us grasp more information to be effective. Moderate anxiety causes selective inattentiveness, okay? And it causes us to have some clear thinking hampering, and it hampers our thinking, I should say, so we don't necessarily think as clearly. It does cause us not to problem solve as optimally as we should, and it impacts and kicks in our sympathetic nervous system, and so hence it begins. So mild anxiety, you guys, keeps us sharp and focused, okay? But we may have some restlessness, some irritability. We might tap our foot, we might bite our fingernails to relieve a little bit of our tension. But in moderate anxiety, we're going to have some inattentiveness, okay? We might not remember all the information that we need to do. Our thinking might not be as clear, okay? We might feel our heart pounding in our chest a bit more. We'll have an increase in our pulse. Our heart might be pounding a little bit more. We might be breathing a little bit faster. We might even be perspiring a bit some, and our armpits might be a little bit more on the damp side. We might even have some mild somatic symptoms of some GI distress, some headaches, some frequent urination, some voice tremors. We might even be shaking a little hand tremors, or our legs might even be shaking. If you've ever done any performance art and have been up on a stage or some debating, some of those things you might be noting that those things happen. So those are just some of those components that you might experience. So when we're talking now about severe anxiety, this is now where we're starting to see perceptual field being impaired or reduced, okay? So when we're talking about this, we're looking at, and it would be very helpful for you to look at page 272, table 15.1, when you're looking at different levels of anxiety. So the perceptual field is being able to see the things around you and what's happening. It's going to be greatly reduced. You're not going to be aware as much of your surroundings. In moderate, it's going to be slightly impaired. You're going to miss pieces of information. So if I were to say to you and you were in class that that the exam was going to be on chapters 5, 6, 7, and 8, you might miss one of the chapters. Instead, you might pick up that we weren't having a test at all in severe anxiety. Somehow you would miss the whole information. You didn't say we were going to have a test. It was going to be the next week, not this coming week. That's how greatly impaired the information would have been twisted. Okay, you'll have difficulties concentrating, confusion, and you're going to have autonomic behaviors. What do we mean by autonomic behaviors? And somatic symptoms increase. But still, what are autonomic behaviors? Confused behaviors become automatic. You go into pilot. You don't even know what you're doing. You're just doing it. Okay? You have no idea of what you're doing. So you can't focus, or you focus in actually on one detail. So you focus in on one piece of information and you don't absorb any of the other information. So I said one thing, and that's the only thing you heard. You didn't hear any of the other information. You can't problem solve, and you're definitely not able to learn information. So this is not the time to try to teach somebody how to deep breathe because they're not able to learn, or try to problem solve a situation. They're going to be in a dazed or confused arena. So it's almost like somebody's in shock. It's a good way of connecting that. Okay. They're going to be having that somatic symptoms of that headache, nausea, dizziness, insomnia. There's definitely trembling. The body's going to be trembling, heart pounding, hyperventilation definitely is going to be taking place there. And they are going to hear your patient say they have a sense of impending doom or dread. It's coming on. It's coming. It's happening. You feel like they're going to be dying. Okay? And then here comes panic. A marked disturbance in behavior. They're going to be running around, shouting or screaming and pacing. They're unable to process reality, impulsive. They can't realize what's happening in the environment. They could lose touch with reality. Lose touch with reality. They can disassociate. What does disassociate mean? Disassociate. They can have almost an out-of-body experience. Things don't seem real. It can be so bad they can hallucinate or have false sensory perception. This could be where maybe a mother loses their child in a store and starts grabbing all these children thinking they're their child, and not realize it's not their child because their sensory's off. They're in a panic, but they're not able to tell anybody that they've lost their child because they're not able to articulate. They're in such a panic. They're erratic. They're uncoordinated. They're having impulsive behaviors. So Anita is a 34-year-old. She's shopping with her 5-year-old daughter in a large, busy urban mall when she suddenly realizes her child is missing. Which anxiety level would most likely result? Most likely, D, panic. If you see her running, pacing, shouting, and screaming, or disassociating, sometimes the word withdraw, and it's not like withdraw and isolate, okay? We're talking about a disassociating type withdraw. Hallucinating, having false sensory perceptions, like seeing people or objects that aren't really there, okay? That would be panic. She may be erratic, uncoordinated, and impulsive. So that would be panic. Otherwise, it would probably be C in severe. Okay? But it'd be one of those two. What behaviors might Anita be exhibiting that would indicate a panic level? So if you pick D, that running, shouting, screaming, pacing, any of that, that's what you would be potentially seeing. If you see dazed, confused with autonomic behaviors and aimed at reducing anxiety, not necessarily. That just wouldn't seem appropriate at that point in time, okay? Because she's going to be looking for her child. All right, defense mechanisms. So this is on page 274. I want you to get that open. You need to make flashcards. You need to do whatever you need to do to get these down. Defense mechanisms, autonomic coping styles. These are things we do to protect ourselves from our own anxiety so that we can maintain our self-image by blocking how we're feeling, our conflicts of how we're feeling, and maintain our memories, okay? They can be healthy or unhealthy. So some of the unhealthy ones that I want to kind of point out here is something like splitting. Okay, splitting is the inability to integrate the positive and negative qualities of oneself or others into a cohesive image. So splitting, there is not an adaptive way of doing this. So this is where it's that love-hate, okay? So because you said no, I can't love you anymore. Because you have I thought I loved you and you were just this great, wonderful friend, but now that I found a flaw in you, we can't be friends anymore, okay? So that, and you disillusioned me. That's the splitting, okay? So I can't be friends with you. That's splitting when it comes to that. But we have stuff, and that's the two I want to kind of go over to just make sure everybody understands for certain, is the difference between repression. Well, actually, we'll start with regression. Regression is when somebody reverts back to an earlier phase in their life or earlier behavior that they don't do anymore, but they regress back to an earlier stage in life, okay, because of something that's happened. So this is like this is an example of an adaptive way. A 3-year-old who is completely potty trained, okay, and they have a new baby come into their family, and they all of a sudden start wetting the bed, or are or they're no longer potty trained during the day and they wet on themselves, okay? And so all of a sudden we regress back into wetting the bed again, or start sucking our thumb because the baby's using a bottle, okay? So that's a regressive behavior, okay? A maladaptive way of somebody regressing is, say you got somebody on the job and they did not get the promotion they wanted. So they start doing sloppy work or missing appointments or late to showing up to meetings. And they regress back into maladaptive behavior, and that would be a maladaptive behavior. So that's regression. So now let's talk about repression. Repression. So repression's the unconscious exclusion of an unpleasant or unwanted expression, emotion, or idea from conscious awareness, okay? So this is where an adaptive form is, maybe you had a fight with your significant other and it's your anniversary and you forgot because you had a fight and you just forgot. Okay, that's a repression, and it's unconscious. It wasn't done deliberately. You just forgot. Okay, it repressed. Versus a A maladaptive example of repression is, say you were raped or had were a person that experienced incest as a child, and as an adult you can't experience pleasure when having sex with your partner. That would be a repression. Okay. And now where I see people get messed up is understanding the difference between repression and suppression. Suppression. Suppression is something that's done consciously. This is where you consciously deny a disturbing situation or feeling. You on purpose, okay, so you do on purpose deny the feeling or the thought, and you deliberately don't want to deal with it, okay? So an example of this is a businesswoman, and I'm reading this right from your book. A businesswoman who is preparing to make an important speech is told by his wife that morning that she wants a divorce. Although visibly upset, he puts the incident aside until after his speech, when he can give the matter his total attention. So he sets it aside, deals with his speech, and then goes and deals with that issue. That's an adaptive way of dealing with suppression, okay? Where a maladaptive way would be a woman who feels a lump in her breast shortly before leaving for a 3-week vacation, puts the information in the back of her mind until after returning from her vacation. Okay, now, should we ignore a lump in our breast? Some people will actually, and 3 weeks after, good, bad, or ugly, no, but how about 3 weeks turns into a year? You feel the lump in your breast and you don't do anything for a year. Don't tell your doctor, don't do dilly squat about it. That is a really rough way. Suppression. You know it's there, but you're just going to deny it. You set it aside. Okay? That is suppression. You deliberately deny it. You know it's there. Okay? So get familiar with undoing, rationalization. Take a look at how you're managing things. Rationalization, we see this sometimes being utilized, especially with abuse. When somebody is an abuser, we see projection happening. So take a look, make sure you recognize the difference with denial, disassociation, displacement. We do see displacement occur with abuse also. So look through these terms, become familiar, be able to recognize them in an exam. Get those flashcards, practice, recognize. All right, so the next thing we're going to go into is start talking about some obsessive compulsive and some of the genetic factors and other factors that contribute. Okay, we have separation anxiety disorders, developmentally inappropriate levels of anxiety and concerns being away from our significant others, usually the caregiver. We see this typically in children and adolescents, where we expect children to go through an anxiety stage of being away from their parents around 6 months to a year of age. That stage comes into play, and we call it stranger anxiety. Okay. However, this can also become an issue when the child does not learn that parent's going to be coming back. Okay. And it can occur later on in life, and when a child is needing to go to school or other elements of life, and how to handle that change. We have panic disorders where a person can experience panic attacks that are sudden and onset. They don't even have to have anything going on, and this attack just will occur out of nowhere, and have extreme apprehension or fear, feeling of impending doom, believe they are losing their minds or having a heart attack, physical symptoms of palpitation, chest pain, breathing difficulties, nausea, choking, chills, hot flash, intense last minutes, and then subsides out of the blue. Agoraphobia. Excessive anxiety or fear about being in places, situations from which you might not be able to escape, and might be difficult or embarrassing. If you look on page 275, table 15.3, it lists some of the clinical names for the most common phobias that exist, such as nycrophobia, fear of darkness, okay, agoraphobia, open spaces, acrophobia, heights, zoophobia, animals. And just so you kind of get a little familiar with some of the terminology that are out there. Claustrophobia, closed in spaces. We will see some of our patients, and one of the things with seclusion and restraint is we do need to ask people about being locked in closets as potential traumas, because being locked in a seclusion room may actually cause further trauma, and they have a problem being in tight, small, closed places. So now we're going to talk a little bit about social anxieties, okay? SADs. So severe anxiety or fear being provoked by exposure to a social or performance situation that will be evaluated negatively by others. Okay, so this is what this person has a fear of. This is what the anxiety is created from. This is their perception. You might see a small child get really nervous, hide behind parents. Some of this can be a piece of normal development, but when this child is doing this with their peers, it's all the time. This is where then you need to start taking a look. Are they experiencing social anxiety disorder? How can I help my child? Older children and adolescents might not do this. What they may do is become paralyzed and immobile, and then what may occur is they actually will act out on people instead and become physical and to get out of the situation. They may have an angry outburst, shove people, hit to remove themselves from the situation. So instead of hiding, they become aggressive and then get out of the area. Generalized anxiety disorder is excessive worrying. So they start to anticipate stuff that's going to happen way before it could even possibly happen. They're going to worry that it is going to happen. And you're looking at them going, what are you talking about? Because they're going to worry that something's going to happen, and it's not even happening or could possibly happen, but they're going to worry it is going to happen. They're restless, irritable, and their muscle tension is off the scale. There's poor concentration, difficulties making decisions, and they'll ponder and worry and think it and worry it and think it and worry it and think it and worry it until sometimes you're going to find yourself having countertransference and go, oh, for God's sakes, just make a decision. Just make it and find out what's going to happen. And seriously, you may find yourself having that countertransference moment because they have to ponder through this and they become paralyzed. Their anxiety can paralyze them to not move forward. And they'll spend so much time prepping, nothing gets done. So can you see the difference between the social anxiety person who's afraid to do something for fear of performance anxiety, basically, because they're afraid somebody's going to see them in negative light in a social situation, versus the general anxiety person who is just worried about everything that could possibly go wrong, and they need to anticipate and plan it all out that nothing can happen or get done. So there's two different scenarios that's being dealt with here. Okay. So if you look at your pages throughout your book, such as for panic disorders, if you look on page 276, there's a generic care plan that's in table 15.4. It gives you a little idea of what you would want to do for somebody with a panic disorder. When you look in page 278 for generalized anxiety disorder and table 15.5, it gives you some short-term goals for generalized anxiety disorder. Patient will state immediate distress is relieved by the end of the session. Patient will be able to identify precipitants of anxiety by date. Patient will identify strengths and coping skills by date. And then it talks about interventions. Stay with patient. Speak slowly and calmly. Use simple sentences. Reassure or assure patient that you are in control and can assist him or her. Give brief directions. Decrease excessive stimuli. So as you're looking at these elements, look at these interventions as these steps, because this is what you want to do. Teach cognitive therapy principles. Anxiety is a result of autonomic thinking with a dysfunctional appraisal of the situation. Ask questions that clarify and dispute the illogical thinking. What evidence do you have? Are you basing that conclusion on facts or on feelings? What's the worst thing that could happen? These are the things we want to be asking our patient. So what is the worst thing that could happen by talking to a people in this group? So those are those things that we want to be asking. So then we have other anxiety disorders. We have substance-induced anxiety disorders that can be caused by alcohol, cocaine, heroin, and hallucinogens. So when it's not in their system, it clears out, but it's keeping them safe while they're under the influence. That is the big issue. And then we also have medical conditions that can cause anxiety: hyperthyroidism, pulmonary emboli, and cardiac dysrhythmias. If you look on page 279, table 15.6, it also lists some other causes of anxiety in addition that are more detailed, looking at respiratory, cardiovascular, endocrine, neurological, and metabolic. And so what you're going to find when you're sitting for your HESI and your board exams, that you're going to have a patient having some anxiety symptoms as you're dealing with their medical disorders. You'll see the anxiety symptoms there, and you're going to be treating both at the same time during your exam. Remember, if you get the oxygen on board, the anxiety will decrease. So remember, safety first, ABCs, and then it will also bring down your anxiety at the same time. So get that oxygen going and acknowledge those feelings as you're putting the oxygen on, that their anxiety will decrease as the oxygen levels go up. So those are some of those things you want to be able to talk with your patient about. So Anita recalls the height of her struggle with panic disorders. My attacks would come out of the blue, usually when I had already been super depressed for a while. They were so bad that I started being more afraid of the panic attacks itself. And this is, by the way, you guys, not uncommon, because I would hear our patients talk about this all the time, because they would panic about the fact and have such fear about a return of a panic attack, it would cause them such anxiety. And sometimes I just stay home from stuff I usually really liked, like high school football games and even slumber or birthday parties, because I was afraid of having an attack in front of everybody. So now we're going to get into obsessive compulsive disorders. Obsessions are thoughts, impulses, or images that persist and reoccur, so they cannot be dismissed from the mind. Okay? So you can have obsessions without compulsions, but you cannot have compulsions without obsessions. So obsessions are the thoughts. These are impulses, images, thoughts, okay, that are going on in the head. And so what the belief is that the compulsions are these ritualistic behaviors an individual feels that drives them to perform, okay, in an attempt to reduce the anxiety from the obsessive thoughts that they're having. So usually these obsessive thoughts, there's a theme. It's usually about sex, violence, contamination, illness, or death. It can also be about somebody breaking into their home, which is part of violence, okay? Their house burning down, violence, getting sick, germs, contamination, again, germs, okay? The most common themes is based on page 279, table 15.7, okay? Losing control and religious concerns, harm, unwanted thoughts of sexual thoughts, perfectionisms, it's needing to organize, labeling things. And you can have traits, okay, of compulsions. You can have some traits of obsessive compulsive. But the difference is when we say somebody's obsessive compulsive disorders is it disrupts their function of life. So you're so afraid your house is going to burn down, you go around and you have to shut everything off 20, 50 times. And so you can't get out of your house because you have to go back over turning everything off or turning on and off light switches. So we usually see this getting started as early as age 3 with lights and locks with little kids, or older kids with contamination and hand washing. Hand washing, oh my God. And when I'm talking about hand washing, you guys, people's hands will bleed. They're painful, they hurt, and they still cannot stop washing their hands. So this isn't something that is just, you know, if it hurts, they'll finally stop. It's not that kind of a thing that they can do. So it's quite serious. And if they could stop, they would, but they can't. So with all of this in mind, there's other different things that we can see. We see obsessive compulsive also in body dysmorphic issues, where somebody's preoccupied with the image of their body. And so we see excessive plastic surgery, okay? Mirror checking, camouflaging, excessive makeup sometimes. A whole mess of different ways you can see this. Hoarding disorders, extreme distress about giving anything away. There's a lot of emotional components tied into objects. There's hair pulling and skin picking, trichotillomania. That is where you're pulling out your hair. And when I'm talking about pulling out your hair, it can be from the top of your head to your eyelashes, your eyebrows, the hair on your arms. I mean, it can be any hair. The dermatillomania is pulling skin scabs, your scabs on your skin, or picking your skin. It can begin as early as a year of age. And then there's trichophagia. We call it also the Rapunzel syndrome. This is where you eat your hair. Now, unlike with cats where you can cough up a hairball, this is where usually we end up having to actually do surgery because it will actually cause you to have blockage in your intestines, and you end up having a blockage and requiring surgery. There's other compulsive disorders, substance-induced. We can have actual substances that can induce OCD, and it can start a month after you've started or stopped using a drug. Parkinson's drugs can actually cause sex, gambling, and spending compulsive disorders. And then there's also medication or medical conditions that can actually induce OCDs behaviors. So there is quite a bit of issues that are out there with OCD. So I just kind of wanted to point some of this out so that you guys are aware that some of this is existing out there in our society. It is a specialized treatment. Not everybody needs to be in a hospital setting. Typically with anxiety disorders and OCD, we don't have them in an inpatient. We treat as an outpatient and in PHP and IO settings. So, patient complains of frustration with his impulse to use tissues, to touch or grab anything and everything around me. I just feel clean and safe doing it that way. But sometimes if I don't have a tissue, I can barely stand to open a door. This patient appears to have which anxiety problem? Panic disorder, generalized anxiety disorder, post-traumatic stress disorder, obsessive compulsive disorder. If you pick D, obsessive compulsive disorder, you are correct. So anxiety disorders are most commonly seen around 21 years of age. It affects women more than it does men. And usually, like we talked about in the depression chapter, we see it hand in hand with major depression. We also know that it is genetically oriented and it runs in families. And we know that it is attached with memory, and it is stored with the emotional center, and it associates with GABA. And we also know that a child who has had strep, and if OCD shows up around that time, we know that there is an association with strep infections and OCD, and it's called PANS. So always pay attention if a parent brings a kid in and they're complaining about some OCD, obsessive thoughts, that child's talking obsessively about whatever the item is, and then compulsions are starting with it. Did they recently have a strep infection within the last 1 to 3 months? There is a high correlation. All right, so psychodynamic theories again. Freud, ego defense mechanisms. Sullivan, anxiety is contagious. Behavioral theorists, learned response. Cognitive therapy, distortions of thoughts and perceptions. And then don't forget, on our cultural consideration, attack of the nerves, culture-bound syndrome. Otherwise, it looks like a panic disorder in our Western world. So what is your usual level of anxiety on the day of a nursing exam? Well, some of you, your answer is going to vary, but we want it to be A, mild. But some of you might be in the moderate and you got a little GI distress. But we'll keep working on bringing it down to mild so you can be functioning at your most optimal level. So, feelings that might be experienced by a nurse caring for a patient with anxiety and obsessive compulsive. We're going to work on formulating nursing diagnosis and propose realistic outcomes for our patients. So, general assessments. We got to work on our general assessments. So we're going to need to make sure we are doing our rating scales. We're going to want to have our patient rate their anxiety levels. We're going to be assessing for depression. We're going to make sure we're going to do our self-assessment and look for our assessment guidelines for our obsessive compulsive, our nursing diagnosis, outcome, and planning. So we need to make sure we do a sound physical and neurological exam. We need to make sure to determine our source of our anxiety, primary versus secondary. We got to do that. Why, you guys? Why do we need to look for these things? Because there can be other causes that are relating to this. There can be infections. There can be cardiac conditions. There can be respiratory issues that can result in these issues that the patient is experiencing. So we need to make sure that we have those elements there. We need to make sure that we are patient-centered when we are looking at our components with our patients. We need to look at their culture again. If you didn't look, by the way, page 282, there is a little cultural consideration about the attack of the nerves that you might want to just read up and reinforce yourself again. You want to make sure that you're looking at your anxiety rating scales for like generalized anxiety to look at the severity and let that patient do their own self-assessment. You want to do your own assessment because do you have attitudes about a person who has anxiety? Do you minimize somebody's situation on how they're perceiving their own anxieties or their situation that they're experiencing? Okay, just things to think about. You want to get a psychosocial assessment. You want to take a look at where all of their stressors are at, where their baseline functioning, how are they functioning in each area of their life, their work, their home, their school, their sex life, their substance use, all those arenas, their spiritual. Now, looking at our nursing diagnosis and our outcomes. This is where we're going to do. So for anxiety, we want to have the patient work on some self-monitoring of the intensity. We want them to use relaxation, use reduction techniques. We want them to maintain their role performance. We want their nursing diagnosis of ineffective coping. We want them to then work on identifying ineffective and effective patterns. We want them to ask for assistance and information and modify things as needed. They're going to have chronic low self-esteem, so we want them to work on verbalizing self-acceptance and increase confidence. There may be self-mutilation, and identify predictable feelings and practice self-restraint. Now, depending on how severe somebody's anxiety is, because if their depression is in there, then we may have to look at suicidal ideation. Because do always keep in the back of your mind, impulsiveness can be an issue with somebody with anxiety. And if they have a panic disorder, a suicide attempt may not be far off if depression is present. So then we got to do planning. Patients do not usually require inpatient like I talked about earlier. But we do want to involve community-based interventions, whether it's self-help groups, support groups, PHP, IOP, outpatient therapy. We want them in community-based interventions. We want to encourage them for planning to increase positive outcomes, and we want to plan experience levels, severe levels may not be able to participate in their planning. So depending on how severe, we may need the planning to come to the home at first and then work on them getting out of the home. So it all just depends upon where they're at in their treatment. So now we got 5 basic nursing interventions to use with patients for anxiety and obsessive compulsive disorders. Got to go over the classes of medications and the advanced practice and basic levels of interventions. So implementing mild to moderate levels of anxiety to severe and panic counseling, teamwork, and promotion of self-care. So Anita recalls the help she experienced when she was treated in adolescence for panic disorders. I remember my dad anxiously driving me to the emergency room while my mom sat in the back seat and held me, just trying to keep me calm. My dad gripped the wheel like he was afraid we were going to go off the road. When we got to the hospital, I remember the nurse came right out of the car and opened my door. She didn't grab me or anything. She just said, "Hi, Anita. My name is Betsy, and I understand from your mom's phone call that you are having a panic attack. Well, I'm here to help you get through it." Then she held out her hand. I've always felt like Betsy saved my life that night. Which was probably the most helpful thing Betsy did for Anita that night? Left her by herself in a quiet, dark space to calm down? Stayed with her and kept her up a steady stream of talk about anything at all to distract and soothe her? Introduced her to a bright, pleasant game with other patients her age to create a much-needed distraction from worry? Or stayed with her in a quiet spot and listened? So when somebody is in a panic state, we want to pick D. We just want to stay with the patient. We want to speak in a low and calm voice. Use short and clear sentences. Minimize the environmental stimuli. And most important, just listen for the themes in their communication. Because it's going to let us know what they're thinking, what their thoughts are. So it can direct our conversation to help guide and help lead the patient to lower their own anxiety. Suppose you are the nurse or the social worker on duty when a child goes missing, but you, unlike Anita's child, is not immediately found. The police arrive on scene. The parent is questioned, and as your search intensifies, you are asked to remain with and take care of the anxious parent. What would be some of the appropriate interventions for helping a parent experiencing panic anxiety? Now I want you to remember, you're not the cop. You're the nurse. You're a nurse that's a stranger, and you're the nurse that's off duty. But you've got this. You have therapeutic communication. You know how to develop a therapeutic relationship. You know how to keep a panicked person, try to help them calm. So you're going to remain calm. You're going to remain with that person. You don't go anywhere. Even though every instinct in your body says you want to do more than what you're doing, what you are doing is so important. It is going to let you help this person, and it is going to remain in their mind for the rest of their life. And you don't realize this now until they come back and tell you this. Regardless of what the outcome is, it will remain with them for the rest of their lives. You're going to minimize the environmental stimuli if at all possible. So that means getting the reporters out of the way, getting everything out, get into the most quietest space you can think of. And one of the best places I can tell somebody is if you're in a mall, the place to go is like dressing rooms where no one else can get in there. Move to the quietest setting possible and stay with that parent. Use clear, simple statements and repetition. So this is also where I would have a runner there that say, go get us some drinks, go get us some cool cold packs, whatever we need. Make sure there's a runner to go running for you because you're not going to leave that person alone. Use a low-pitched voice because they're going to have difficulties hearing, and the deeper your voice goes, the better they're able to hear. Speak slowly. Recognize their anxious person's distress and just be willing to listen. So pharmacology interventions. The SSRIs, Paxil and Zoloft. SNRIs, yes. FX or Cymbalta. And the TCA anafranil is great for using for hair pulling. We need to, for short term, we can use the antidepressant or the anti-anxiety benzodiazepine. And somehow, some way, and I do not know how it happened, you guys, but I did not type on here buspirone, otherwise known as Buspar. It is on page 288. Page 288. Okay, make sure you write that one down. 288. Make sure you read up on that one. This is the long-term anti-anxiety medication. It takes 2 to 4 weeks for it to kick in to work, or 2 to 4 weeks for it to start working so it reaches its full potential. Okay. And its side effects include dizziness, nausea, headache, and nervousness, and lightheadedness, and excitement. We never give it at bedtime because it was going to cause a person to have insomnia and not get to sleep. We want to give it in the morning because it does not cause sedation, okay? But we need to make sure that our person knows and remembers that it doesn't kick in right away, so they might be on a little benzo in the beginning to manage their anxiety. But also, this is not recommended for anybody who has hepatic or renal failure, and we always have to check their liver and their kidneys out periodically to make sure things are good. So that it doesn't create any other problems. We can also, of course, use beta blockers and antihistamines and anticonvulsants to help manage anxieties. And once in a blue moon, we can also use an antipsychotic medication to help somebody with severe anxiety. So especially if they are having any hallucinations or severe agitation. Those are something that we are able to use. Okay, so those are listed up there. So you are aware. Usually with generalized and socialized social anxiety, gabapentin and Lyrica are two of the anticonvulsants that I have seen pulled and used for treatment. For children and adolescents, I do want to just mention that we typically have not seen SSRIs except for Cymbalta be approved for use for generalized anxiety disorders. So you are just aware of that. So just to kind of give you an idea, we're still waiting for some approvals, but we still have seen anafranil, Prozac, and Luvox, and Zoloft used off labels for them for generalized anxiety disorders. Or wait, take that back. For obsessive compulsive disorders. I'll get it out of my mouth yet. Those have been approved for obsessive compulsive disorders. Read through the patient family education regarding the use of anti-anxieties again, because again, all of these are central nervous system disorder. Affect the central nervous system. So again, fogginess, um, impaired judgments, motor vehicle driving, no alcohol usage, there's risks to fetus, all these things that are potential items that we need to be careful with when our patients are being treated. Other interventions that are out there are deep brain stimulation to help reduce anxiety. We want to do integrative therapies along with health teaching exercises. So we do use a lot of cognitive therapy and behavioral therapies such as relaxation techniques. Modeling. What is modeling? That's just like it sounds like, you guys. Modeling behavior, showing somebody how to act. We role model the behavior is the best way as I can word this. Role model how to do something, okay? How to manage and go through a situation. We use the systematic desensitization, and that's how, just to remind you guys, that when we fear an object, we slowly expose ourselves to the thing we fear and work on relaxation exercises as we expose ourselves to the thing we fear until we are able to actually expose ourselves live to the situation. Then we, of course, have flooding, which is very different from systematic, because what we do is we go and we expose ourselves completely and totally to the item we're fearful of. So one of the things that always came to mind is there used to be a show called Fear Factor, and I hate bugs. That's a good one to give an example of, okay? And they used to have people get in a container and dump bugs on top of them. And that would be flooding for me. If you just would go and dump a whole mess of bugs on top of me all at once, besides the fact I think I would probably die, that would be a flooding experience. And you'd leave that person in there for like up to an hour at one particular moment of time with that on top of you. It's supposed to cause you to lose your anxiety over it, supposedly. I don't know if it's feasible, but that it's supposed to. I don't know. I have my own fear issues, so I don't know how well it works, but there is supposed to be evidence-based that actually works. Okay, response prevention. Okay, this is used for compulsive behaviors, okay, and this is where the therapist doesn't allow the person to perform ritualistic behaviors. Now, we don't do this. This is something that's done in the office. Now, if we have an obsessive compulsive person on our units, when for some reason that we have somebody that's actually in our hospital setting, our intervention for them is to do social distraction, because you cannot interrupt the behavior. It's just not going to work. It's actually going to cause the person to cling on to it very tightly. It's just the same with somebody who is delusional or having a hallucination. The more you argue with them about the thought, about the behavior to stop it, the more they're going to hold on to it tight and argue with you, the more they're going to believe it and do it. So what you're going to do is distract it. So for my easy example, I had a 4-year-old who was very obsessive compulsive, and he was washing his hands till they would just bleed. And one of the things he loved was trains, and he loved storytelling. And so he loved reading books. And I would have we had some other little kids with us at the time. And so one of the things I would do when he would get off track and try to wash his hands is I would pull the train books out and start reading them to the other kids. And he just couldn't stand it. Those train books were just much more important than that hand washing. And I would start reading out loud, really, really loud, and he'd try to wash and listen at the same time. But what I'd start to do is talk a little softer and a little quieter. And so all of a sudden, he'd have to come out of that bathroom because he couldn't hear it. And it was too important of a story to miss. And so he'd have to give up his hand washing to come sit and read and see the pictures in the book. And so this is how I would socially distract him. We do the same thing with adults. It's time to go do such and such, and the patient would eventually come out. It would take them a few minutes sometimes, but they would be able to come out of their bathroom or whatever the activity was and be able to assist us. If any of you ever watched the TV show Everybody Loves Raymond, and his older brother would have to touch his chin before he would eat an item. Now it's a ritualistic behavior, okay, that he does. It's not super disruptive, but it's still a behavior, and there is a thought that's going on that he's having. There's an obsession that's taking place to relieve his anxiety when he's eating. So just give you some thoughts about some of those things that we see. Okay. Response prevention. What is response prevention? Oh, I did that one. Sorry. Totally forgot. Okay, so then we have thought stopping. And this is where we interrupt the patients and tell them to stop. Or they wear a rubber band. So sometimes one of the things I do is when I have students who change their answers on their tests because they start to doubt themselves, I have them wear a rubber band and snap it to make them stop erasing their answers when they're doing paper tests. You made the change, snap it, move on. Inflict a little pain to make yourself stop your behavior. That's what a stop it's about. Okay, so it's just to remind you to stop it, change your thought, move on to the next thing. And then, of course, we have our cognitive behavioral therapy. So we reframe what we're saying and doing. Okay, so now we're going to evaluate. So what are we looking for? What are we measuring? What are we making sure that we're having improvement? So is this patient experiencing a reduction in their anxiety? Does the patient recognize the symptoms as the anxiety relates? So what are their symptoms of anxiety? So how do they know there's a reduction? We need to see it. Do they have sweaty hands? What are their anxiety related symptoms? So they recognize when it's starting to onset, and is there a reduction in them? So they can intervene. The earlier they can recognize the onset of the symptoms before they're so severe that they can't stop the process, the earlier they can recognize. So if they hand sweat and they start deep breathing then, versus the fact that they're hyperventilating and then trying to deep breathe, it's much more difficult. Okay, makes sense? Does the patient continue to display signs and symptoms of obsessive compulsive, phobias, or worrying, or other symptoms of anxiety disorders? If still present, are they more or less frequent, or more or less intense? So basically, how often are they occurring? Are they occurring less often? Are they less in duration, or more? How are we doing? How's that patient doing? Is the patient able to use the newly learned behaviors to manage the anxiety? So are they using their new skills? How easy is it for those new skills to be used? How often are they using those new skills? Does the patient adequately perform their self-care activities? Can the patient maintain satisfying interpersonal relationships? So how are their relationships doing? Is the patient able to resume usual roles? So, and this is important. So how's the sex life going? So they might have, the communication and everything going on, but they quit having sex. How's that affecting their interpersonal relations? All those questions have to be talked about. Okay, so quality improvement. Quantitative measures. Severity of the disorders. The Global Impression Severity Scale. Okay, Clinical Global Impression Severity Scales. These are some of the things we look at measuring. The developmental of outcome and guidelines. 80% of the patients with anxiety disorders are monitored every 6 weeks. After 6 months of treatment, 50% will score less than 3 on that scale. Monitoring patients' progress. So NCLEX questions. Which best amplifies an individual's use of defense mechanisms of compensation? A woman feels unattractive but decides to pursue fashion design as a career. A shy woman who abuses alcohol tells others that alcohol helps her overcome her shyness. A poorly paid employee consistently yells at his assistants for minimal mistakes. A teenager injures an ankle playing basketball and curls into a fetal position to deal with pain. So, remember, compensation is a method of covering up real or perceived deficits by emphasizing a strength. So if you picked one, you got it right. After filling an examination, a physician in his psychiatric residency begins smoking a pipe and grows a beard to look like Sigmund Freud. The nurse manager realizes the physician's insecurities, recognizes the use of which defense mechanism? Identification, repression, regression, or reaction formation. If you picked identification, you are correct, because this is somebody trying to acquire attributes of the person they admire. Which would the nurse expect to assess in a client with long-term maladaptation to a stressful event? Diarrhea, a pulse 100, blood pressure 150/94, profuse diaphoresis, ulcerative colitis. If you picked ulcerative colitis, you are correct, because remember, we're talking maladaptive long-term. 1, 2, and 3 are short-term events. The ulcerative colitis is long-term. It's from a long-term issues going on. Go back and look over chapter 10 if you do not recall this. In which situation would a nurse suspect a diagnosis of social anxiety disorder? A client abuses marijuana daily and avoids social situations because of fear of humiliation. An 8-year-old child isolates from adults because of fear of embarrassment but has good peer relations in school. A college student avoids taking classes that includes an oral presentation because of fear of being scrutinized by others. If you pick 3, you are correct. Now, I know some of you may have wanted to go for 1, but the reason 1 isn't is because this person's abusing marijuana daily. So is this substance abuse anxiety? We have substance in use there, so you cannot know that it is actually social anxiety induced because of the substance usage. A client has a nursing diagnosis of disturbed sleep pattern related to increased anxiety as evidenced by inability to fall asleep. Which correctly written short-term outcome is appropriate for this client? The client will use one coping skill before bedtime to assist in falling asleep. The client will sleep 6 to 8 hours a night and report feeling of being rested. The client will ask for prescribed PRN medication to assist with sleep by day 2. The client will verbalize his or her level of anxiety less than 3 of 10. Remember, you need to use SMART: specific, measurable, achievable, realistic, and time frame. So the only one that fits all of that would be number 3. During the intake assessment, a client diagnosed with generalized anxiety disorder rates mood at 3 out of 10, rates anxiety 8 out of 10, and states, "I am thinking about suicide." What nursing intervention takes priority? Teaching relaxation exercises? Ask the client, "Do you have a plan to commit suicide?" Call the doctor to obtain a PRN order for analytic medication. Encourage the client to participate in group activities. Oh, and you guys, what's analytic or another name? If you said anti-anxiety medications, you are correct. So what is the answer? If you pick 2, ask the client, "Do you have a plan to commit suicide?" You are correct. Which of the following medications can be used to treat a client with anxiety disorder? Select all that apply. 1. Catapress. That's for panic disorders and generalized anxiety disorders. 2. Luvox can be used for OCD. 3. Buspar for generalized anxiety disorders. And 4. Short-term treatment for anxiety disorders. Those are going to be the primary ones you would select. Haldol is going to be held off for very severe, so we are not going to pick that. That is not going to be an option that you would put on your first choice for an NCLEX question ever.